Welcome to my Q&A session. Hope everyone's prepared for the exam. I know for some of you, it's actually tomorrow. Some of you are writing on Thursday. I will be online all night, and I have some time off on Thursday and Friday. So if you do have more questions, you can just post them into the exam forum, and I'll try to answer them as soon as I can. This is meant to be a very casual Q&A. I'll try to get to all your questions. Yeah, so just relax. This will be a casual session. I'll just kind of go in the order of the questions I received. You know, for some of you, I see that you're doing like really, really well. Your questions are really, really detailed. It's also important to not become too focused on the details. You know, the question is made by people, it's not made by people who are omniscient about diabetes. There's still lots of things about diabetes we don't know. So, you know, you just have to pick the best answer out of the options, and try not to change your answer as well. So a couple general tips. One is that first thing you want to do is relax for the exam. You don't want to be anxious. If you do find yourself getting anxious for the exam, then take 7 deep breaths, 7 being the target A1c. So try to relax for the exam. Number 2, try not to change your answers too much. Generally, people who have not passed have changed their answers a whole bunch on the exam. So usually go with your first gut reaction. That's usually the right answer. And then third is to try not to overanalyze the question. Well, read the question carefully. That's why I put all those kind of not questions to kind of trick you and everything. A lot of people will come out of the exam and they're talking to other people, and it's like, hey, didn't you get that question on so-and-so? It's like, no, like they was asking for this. And so, you know, it's like they wrote in a totally different exam. So make sure you pick the right, make sure you slow down, relax, and slowly read the question. Yeah, so those are just some general tips for the exam. I'll start answering the questions that I received. Okay. If they're not here, maybe I'll just hold them till the end. Is Gina here now? Well, actually, here, I'll just go into order. I think that'll be easier. So, you know, Gina's struggling with organization of the care questions. So yeah, those questions are always tricky as well. They kind of seem to come from left field, those educational questions. So it's not you, it's everyone else as well. And so I do have in my how to study guide, competencies. There's some options here for studying those educational questions right here. For the educational research competency, I have some suggestions for what to read and what to read in essentials if you have it. I had this guide here. I think one of the questions came up on my exam, so that's why I posted it here. So just take a look at that. This focuses on organization of and standards of education. So give that a read and see if that helps you out for understanding that competency. Okay. Okay. Next one, Allison. So maybe I'm missing something. Yeah, so the appendix that you find here at the appendix here was from the 2018 guidelines. That's why it doesn't match up with the 2020 update. You're talking about this one, yeah. So this came out in 2018. But the 2020 update for the medications came out in 2020. So this supersedes the 2018 guidelines. So you should be looking at the renal functions and the suggestions from this guidelines, especially in this gray area down here. It has different, oops, here we go. It has different guidelines because, you know, there's been new research on SGLT2 inhibitors. They're actually used a lot not even out of diabetes now. They're commonly used in the guidelines in heart failure and things like that. They've been shown to, you know, if your renal function is good, it reduces your chance of hospitalization of heart failure, preserves your kidney functions, reduces your blood sugar. But even if your kidney function isn't good, you lose that. It doesn't like you need good renal function for it to excrete sugar out of your system. If your renal function isn't good, then it won't excrete sugar. So it loses its glycemic effect. But it's the more recent studies have shown that even at lower renal functions, it still has a benefit for preserving renal function. It still has a benefit for reduction in heart failure. So for those reasons, they updated the guidelines, and you should be memorizing these guidelines here, not the ones from the appendix before. Yeah. Allison, if you're online, does that answer your question? Okay, so I'm just going to move on. Why are there two different sets of guidelines? So basically, it's because the guideline writers don't know which one's best. You know, they haven't done an experiment to see which one's better. But if you ever done research, it's very difficult to get approval from ethics and stuff like that. And, you know, it's unethical to test on pregnant women. So in a nutshell, they don't know which one's better. That's why they've included both methods. You know, if it was your job to say which one's better, but you don't have evidence that either one is better, then you just have to show what most people are commonly doing in diabetes and pregnancy clinics. I don't have okay, it's bigger. I will try that. 1 second. Let me see if I can put a zoom on this. 1 second. There we go. Okay. Where was I? Oh, so yeah. So it's because you know, there's no research to show either one's better. I don't work in a diabetes and pregnancy clinic. It's kind of like a specialized clinic. So I don't know what's commonly used out there. But that's why the diabetes and pregnancy chapter is so long, is because they don't completely know what's best. And so if it was your job and you don't know what's best, you just write it, what all the evidence out there and what everyone's doing in practice. Yeah. Okay. UKPDS. So for the UKPDS, for the landmark trials, I definitely think you should know kind of the statistics and things like that, how much it reduced retinopathy and stuff like that for those big landmark trials. For the other trials, like the drug trials, I don't think you need to know everything. You just need to know it as a class. Like you need to know as a class, SGLT2 inhibitors preserve renal function, or as a class, you know, most of the GLP-1s show improvement in cardiovascular outcomes, or as a class, the DPP-4s show no improvement in cardiovascular outcomes. You don't have to memorize like Carolina or Timmy or Savor Timmy and stuff like that. You just kind of have to know which ones showed benefit and which ones didn't. And let me see here. Is it still relatable? No, I think with all the new medications, like a lot of the medications have shown that they preserve beta cell function. And so I don't think that that timeline of 6 to 10 years is accurate anymore. I have lots of patients that I've followed for 10 plus years, and they're not on insulin and they're doing quite well just on orals. It doesn't mean that diabetes has stopped being a progressive disease. It's still a progressive disease. Those beta cells still will kind of diminish, but with these newer medications, I don't think that timeline of 6 to 10 years is accurate anymore. Yeah. Okay. How CKD falsely lowers or raises A1c. So I'm going to actually ask some help from the audience. Was anyone here? Did anyone here also attend Dr. Peterson's presentation? Does anyone remember what she said about this? I know that was a question asked, but I was busy admitting people and moderating the chat, and I don't remember her answer.
She had said that it can do both. She had said that one way, if I remember correctly, it can change the lifespan of the blood cell, but then there was also the erythropoietin aspect to it. If you have less erythropoietin, then you can the A1c can increase. So, but yeah, from what I remember, she had said it can do both.
I can do both. Okay, so but let me explain that. So commonly, if you have if you have a lack of erythropoietin, then you're not making as many red blood cells. Oh, perfect. However, she said that one, yeah. So I can't remember which direction was the one that's more likely. It can do both. So on exam, it isn't wrong to say both. Thank you, Robbins, for checking your notes and trying to see that. So there's two ways it can increase and decrease. So the kidneys make erythropoietin, which is the hormone responsible for making new red blood cells. If your kidneys are malfunctioning and have dysfunction, it's not making erythropoietin. So your body has to use those red blood cells for longer. Remember, the A1c is a measure of how much sugar is coating the red blood cells, or the glycosylation of the glucose. And so the longer, you can kind of think of it as like glaze on a donut. The longer the donut sits in the glaze, the thicker the glaze becomes. So if your sugars are really, really high, there's more and more of that glaze on the red blood cell, and the red blood cell lives for about 3 months, and that's how you get an A1c. You're looking at how much glycosylated hemoglobin is there, or to explain to patients, I'm looking at how much glaze is on that donut. Now, if you're lacking erythropoietin, you're not making red blood cells. So your body is forced to use those red blood cells for longer than usual. So it's sitting in your blood for longer and collecting more and more sugar. Now, it's not that your sugar is actually higher, it's just more sugar residue is on that red blood cell. So that's how it could falsely elevate your A1c. Another scenario in which it decreases the lifespan, there's certain renal diseases that can shorten the red blood cell lifespan. And so in that case, if you have a shorter lifespan, it does the opposite. It falsely reduces your A1c because those donuts don't have as much time to collect that sugar residue in the blood because they're destroyed by some, okay, no worries. Because it's destroyed by some reason because of some faulty kidney functioning. So that's how it can falsely elevate and falsely lower it. There is this as well, I found. If you have chronic kidney disease, sometimes you also have anemia. Anemia forces you to use your red blood cells for longer. That falsely elevates it. Apparently, there's some reactions, carbamylation of hemoglobin, acidosis. Those are things that can happen in people with chronic kidney disease, and that falsely reduces the lifespan, which falsely decreases the A1c. So the answer is both. Chronic kidney disease can go either way. Yeah.
But she did say that if it was in an exam setting, it was most likely to go down.
Go down. Okay, thank you.
That's what she very much stressed. So basically that goes with what you were just reading type of thing with the lifespan of the kidney and the hemolysis and stuff like that. That seems more logical anyway.
Perfect. Thank you. Thank you so much for that. No, thank you for seeing that. So yeah, so it would be on exam, she would say that it would go down. That's the more likely, but it's not wrong to say that it can both increase or decrease the A1c. Yeah. Okay. Okay, so Masadi asks about, the stats. Again, the stats, for the UKPDS and DCCT, I would, because they're landmark studies, those ones I would study and memorize. For the other medication ones, I would just kind of know the class effect, which ones had benefit. Appendix 9. Okay, let's take a look at Appendix 9. Okay. Yeah, I think just reading this would be good enough for the exam. They've kind of switched, for the last couple of exams, they've switched kind of away from trying to do like insulin carb ratios and insulin sensitivity factors. Definitely they do have some questions on initiating insulin, but I think they've gotten away from really hardcore insulin calculations for the last couple of exams. I remember my first one had a bunch of hardcore questions on that, but the last two I've written have seemed to gotten away from that. So definitely I think Appendix 9 is all that you need.
I was just wondering too, Esmond, sorry,
Yeah.
Masadi here.
Oh, hello.
Hello. So yeah, because I just recently attended an in-service about pumps in children. And
Okay.
I've noticed that the titration and insulin starts were different than what's in the guidelines. So that's kind of triggered the question of whether or not that would be the case for the exam, or if it would just be kind of across the board for Appendix 9.
So remember, so I would say that's probably Appendix 9. Like pediatrics is a bit of a specialty item, specialty program, and that program might be different from province to province. But remember, it's a national exam. Your exam is the same as everyone else in every province. So they wouldn't have like, okay, in Ontario, you do which ones and stuff like that. It's a national exam. So I doubt they would have like something as specific as insulin titration for pediatrics. So yeah, I would say Appendix 9 would be enough for the exam.
Okay, perfect. Thank you.
Yeah. Okay. And I believe you had a question about Forxiga too, right?
Yes, I did. So
yes.
that was around the bladder cancer. Just because I've been hearing some conflicting messages about bladder cancer and then risk with dapagliflozin. So I just wanted to clarify, because I think I recall with one of your cheat sheets that indicated that for this year's exam that it doesn't cause bladder cancer, but then I'm hearing that it's still used with caution. So I'm just kind of unclear of what I would select as an answer for the exam for that one.
For sure. So I attended that frontline forum as well. So I'm kind of surprised they said that, because this is a Health Canada drug product database. This has all the latest product monographs for the drugs. And so if you look up Forxiga, the latest monograph for Forxiga, they've removed that bladder cancer yeah, see, in a 6-month bladder tumor initiation, the results show that dapagliflozin does not act as a promoter or progressor of bladder cancer. And if you look at their black box warnings, there's a long monograph. Okay, if you look at their black box monograph, yeah, it's just diabetic ketoacidosis. So for me, I would, for both real life and exam, I would still put that Forxiga there's no risk of it with bladder cancer. This came out, when was this updated? So this came out in 2021, and the guideline update to the medications came out in 2020. So I think that's why I think it wasn't in time to get that removed, but I think in the next iteration, it will be removed. The deadline for new information for the exam is February 1st, 2022. So since this came out before then, I would say on exam that you would choose Forxiga does not have anything to do with bladder cancer.
That's helpful. Thank you.
No problem. Okay. Heisman, 3 times a day. Okay, so that was in the new update as well. So if you look at the, okay, let me see here. So it used to be, yes, it was, I wish the guidelines were more clear with that as well. But it used to be you would test sugars as many times as you're taking insulin. But in the new guidelines that just came out in 2021, if you look at the recommendations, if you're using insulin more than twice a day, I believe, yeah, 3 times per day, I believe. Yeah, in individuals using insulin more than once a day, you should be testing sugars at least 3 times a day. So that's where that question came from. And because this guideline came out, this supersedes the old chapter because it just came out last year. So that's where that testing 3 times a day comes from. Oh, another DUP. Yeah, I guess that's a common question. Okay. Hi. Okay, for sugar alcohols. Yes, so for sugar alcohols, they're erratic in their conversion to sugar. Sometimes they convert into sugar somewhat, sometimes 50%, sometimes less. So it's better to have a person's sugars a little bit higher than a little bit lower. So you should not count sugar alcohols as carbohydrate in calculations. I do that in real, like some people in real life count it as 50%. You could do that, but I'd rather be safer than sorry. So in real life, I also count that as 0 as well. So just like fiber, I count both as 0 as in insulin carb ratio calculations. And there's this discussion in that in the exam form. You can just look for that. You can just Google sugar alcohols in my exam form, and that will lead to the conversation. But in real life and on exam, I'll count them as 0. Okay, Ritu, the guidelines are just right here. You can just follow this link. Okay. Okay, so yes, there always seems to be a travel question. So I've actually put a whole bunch of examples in the how to study section. If you go to competencies and you go to there's two places it's in. It's in special situations right here. I do have a presentation by Dr. Halprin that goes into it. It's just loading up. Is there anyone else coming in? No. Yeah, so there's also a presentation here that goes over it. If you look, so that's right here, that's in the how to study section under special situations. Also, if you look up here in this Saskatchewan insulin dose module, there is an example on page 25 and 22. So you can just look there for examples on how to adjust insulin for travel. Okay. Is duration of diabetes a risk factor for diabetic neuropathy? I guess so. Like if you've had diabetes for a long time, that puts you at risk for diabetes neuropathy. Was there something specific about that you wanted to ask, Heather? Did you have like some context around that question? Okay. All right. So yeah. Okay. Thanks for the Q&A update. Okay. So here are some. This is from Lisa. So these are some questions. These are some just some general tips. Try to remain calm. Go with the first answer you selected. Also remember to not waste too much time on one question. So remember, on your exam, there's 165 questions. So you have about 1.25 minutes per question. But remember, out of those 165 questions, there are 25 pilot questions. Those are questions that they're putting to make sure that they make sense for next year, but they're worth 0 marks. So let's say you spend 30 minutes trying to answer this pilot question just to make sure you get it right. Guess what? You get 0 marks. If you skipped it because you didn't want to waste time, guess what? You'd also get 0 marks. Those count for absolutely nothing. So if you're really stuck on a question, maybe it sounds confusing or you don't really get the wording, maybe it's just a test question for next year. That's what they're doing. They're testing to see if the wording makes sense so that they can use it for next year. Oh, and here, Laura, I'll get to you in just a sec. You raised your hand. What was I saying? Yeah, so it might be a test question in next year. Don't waste your time on those. And, there's a lot of questions. Oh, I copied and pasted this wrong, but anyway, there's a lot of long questions where it's like, which of the following are incorrect and has a whole bunch of things. So what you want to do is you want to kind of look for what's wrong. So which of the following are all fruits? So I know cake isn't a fruit. So you can just cut out all the ones with cake and then cut out the donuts. You're looking for ways to just kind of shortcut yourself and reduce the time that you spend on each question. Laura, you have your hand up?
Yeah, thanks. My question is in regards to, but I know you've mentioned that we need to pass each competency.
Mm-hmm.
What is considered a pass?
So that's a good question. I just talked about this in the forum. Just give me 1 second. So let me show you guys what I said. So they use this thing called the, what's it called? Angus deformo rating. Angus, where did that go? I just answered it yesterday. Okay, I thought I just answered this yesterday.
I saw it yesterday as well, but I think at the time you hadn't answered it yet.
This one, right? Oops. Yeah, okay. So the CD uses a term called the modified Angnoff method to determine if you pass the competency or not. I don't understand that calculation. From my understanding, it just seems like the class average. So basically, as long as you beat the class average, then you pass the competency, it seems. Yeah. Does that answer your question, Laura?
So it's kind of like a curve?
I think so. That's how I understand it.
Okay.
It's not marked on a curve.
Hi, Denise.
Oh, sorry. I was reading one of the guidelines and it said that it's not marked on a curve, but yet still it's marked on a curve. So I'm not sure. It's quite up in the air, to be honest.
Yeah, I don't, the CD ECB is quite opaque and hidden about that kind of stuff. So other than this modified Angnoff method that they mentioned, I don't know how to determine it. Anna, you have your hands up?
Sorry, just related to the same thing.
Yeah.
If you do fail the exam, does it give you a breakdown of like which competencies you passed and which you failed?
It does, yes.
Okay, thank you.
I did used to have like a fail letter that I put up just so you can see what it looks like, but then the CDECB got mad at me and asked me to take it down for some reason, so I did. Okay, I'm just gonna. Oh, Laura, you have your hand up again? Or
Yeah,
is that...
thanks.
Oh, okay.
Yeah, I put it back up. So I recall reading that it takes several weeks to get your results. Did I read that correctly?
That
we
is
write
correct.
the exam and then we don't hear anything for
Yeah, I know. It's
weeks,
kind of
months.
I know it's kind of ridiculous, but that's how they operate. And I don't know why. It's especially with Top Hat, it's an electronic platform.
From someone that wrote the exam last year, they said it was about 3 weeks. They got an email and then a week later they got the physical letter.
Oh,
so it wasn't as bad as it used to be, but still a couple weeks.
Okay, that's fast. I was thinking it would be longer and that I would just be in agony waiting and
Yeah. Oops, someone's trying to join. Okay. So yeah, it's never been months, like maybe a month or two at the most, even when it was on paper. Yeah. Okay, so Vanessa, the guidelines mentioned do resistance exercise before aerobic exercise to reduce hypoglycemia. Okay, so what happens with that is that when you do high intensity exercise, and you can try this yourself as well if you get a Libra. Like I actually encourage you guys to call your Abbott rep and try. They'll give you a Libra to experiment on yourself if you want. And so if you do high intensity exercise, you'll notice that your sugars increase. Why is that? Remember in the pathophysiology lectures that your liver stores 75 grams of glycogen. And when you're doing high intensity exercise like powerlifting or something high intensity, your sugars will increase because your liver realizes, oh, I'm in a high intensity situation. I need to start pumping out all the sugar. And so it's good for people with type 1 diabetes. That actually helps prevent those because now they've got all the sugar in them from the liver. And then if they do aerobic exercise, then it reduces their risk of going low. And they've done multiple studies that have shown that it's kind of an effective treatment to prevent exercise-induced hypoglycemia for people with type 1. So yeah, there's lots, you can Google it. There's I can't remember her name. There was a physiotherapist up at University of Alberta who was actively doing research on this. And she had really fascinating tips for people with type 1s, but if I remember her name, I'll post it on the Q&A. But she made an excellent presentation on this kind of stuff. Yeah. Why is it suggested to exercise 3 hours after a meal? I'm guessing maybe that's the peak of the meal, and then if their sugars have peaked after a meal, then they won't go low. Why can't we put insulin back into the fridge once it's open? Insulin is a fragile protein. You can think of it like a paper origami, but with amino acids. Once you put it into room temperature, it starts unfolding. Just kind of like meat, it starts rotting after you take it out of the fridge. Once it's out of the fridge, even if you put it back in the fridge, that unfolding process is still happening. Like just the same, like if you took a piece of meat out, it rots, and then you put it back in the fridge, it doesn't make it perfect to eat anymore. It's still rotten. And since insulin is just like an amino acid, just like meat, the same thing applies to that. Why is A1c not considered a valid diagnostic test for type 1 diabetes? So this has a kind of caveat. So you can, but it's not recommended because people with type 1 diabetes, actually, I think I answered this in the exam form, but I'll answer it right now anyway. People with type 1 diabetes can convert from normal to type 1 diabetes very, very quickly. So especially, it seems the younger they are, the faster they convert. So for example, let's say some kid has a sugar of 4, but then they convert to type 1 diabetes very, very quickly, and their sugars are 40 in a week. So if you take that kid's A1c, remember, A1c is an average of the last 3 months. So for 1 week, their sugars have been 40, but for 11 weeks, their sugars have been 4, completely normal. So their A1c might not actually be that elevated. And so if you just went by the A1c, oh, you're perfectly fine. For some reason, your A1c is 0.1, 0.2 higher, you're perfectly fine to go. That kid would probably not survive another 3 months of sugars at 40, waiting for his next A1c. That's why it's not considered a valid diagnostic test. Doesn't mean you can't use it, but if you suspect type 1 diabetes, you would do a fasting blood glucose or random blood glucose to show that 40, and that way you would diagnose them. Yeah, does that answer your questions, Vanessa? Oh, geez, there's a lot of questions in the chat. Okay, I'll go to the chat now. Sorry, which studies? Yeah, UK, PDS, and DCCT. For initiating basal bolus in peds, to use 0.5 units or less. I actually don't know anything about peds. I've never worked in pediatrics, so I wouldn't have any. I don't have any advice for that.
So for the exam, if it asked like a starting dose, would you use that, or you don't think it would ask a starting dose for peds? I
don't think it would ask the starting dose in peds. That's more of a usually like the only experience I've had in peds is that the family doctor wants me to take a sugar of this really sick kid using the meter, and it's like, oh, it's like 30, time to send you to the hospital, and that's the end of it. I doubt that they would ask you. I would probably, like, you could try studying that, or you could spend your time on studying it for adults, which is the 99% probability of the question showing up on an exam. So there's maybe a 1% chance that it'll show up on an exam, but I wouldn't waste my time studying for every possibility. Oh, here, starting. Okay, yes, thank you. Thank you for mentioning that, Kristen. Thank you. If a person is using basal once, yes, I believe that's just once. If you look at the guidelines, updated guidelines, I believe it's just once. It's only if you're using it more than once do you do it more than once. Let me just see here. So, yeah, at least once a day. Once daily insulin. Yep, so once a day is good. Oh, thank you. Thank you, Felissa, for answering. Or maybe I should skip further. Okay, so on Top Hat, you can actually download Top Hat right now. They should have sent you a link to experiment with it. On Top Hat, I wrote it last year as well. It's just one big blob. Like you don't. It's just the question and then the answers. Questions, answers. There's no forward backwards kind of thing like my exam does. My exam has that because I want you to see each question and then see the answer if you want it. But on Top Hat, it's just one big blob. You can just scroll up and down to see the questions. But I would recommend downloading Top Hat right now and just playing around with it just to get comfortable with it. The more comfortable you are with Top Hat, the more calmer you'll be on it with the exam. And there's pros and cons to Top Hat. Like when I wrote on paper, you weren't allowed a calculator, which you are allowed now. You had to kind of wait in line for them to admit you. They had to like check your ID and stuff like that. One of my friends actually forgot their ID for the exam. And it was super stressful for her because then she had to prove that it was her. And she got a ride from a friend. They carpooled for the exam. And then she had to like prove that it was her and stuff like that. So there's pros and cons to writing for Top Hat. Laura, you had your hand up?
Speaking of Top Hat, when I've done the simulation and I hold my ID up to the camera, it seems to take a really long time. It's like it doesn't work properly. And then it gives you this warning that the clock is running and you're wasting time, but it's not scanning my ID. Has that happened to other people as well?
It took a long time for me as well. And the room scan took a long time for me as well. I guess you could try playing around with the resolution settings on your camera to just try to set at a higher resolution. That might help a bit. But otherwise, you can just maybe try logging in early, scanning in the ID and doing your room scan, and maybe that'll help.
It gives you an option to scan it manually, like it will time out after a bit, and then you can just take a picture.
Okay.
That room scan, can I ask a question? Do you have to walk around with your computer, or do they just do it with the camera type of thing? They're obviously checking whether you have your stuff lying around type of thing.
Yeah.
I tried the room scan today, so it wasn't really clear what I was supposed to be doing type of thing. So that's why.
Yeah. So for the room scan, you don't have to like walk around. You just have to kind of show them the immediate area. If they're suspicious, the proctor will show up and ask you to scan stuff. So just try to do a room scan. Make sure no one comes in or out that will trigger the proctor. Try to don't like you might be in a room, but if you have people walking behind you, if you're in the kitchen and your kids are eating stuff, they'll definitely flag you for that. So do it in a room where no one else is there. I had a student ask, like, was it okay kind of to mumble to yourself as you, because she's a kind of a mumbler. She likes to talk to herself as oopsies, there's people here. She likes to kind of talk to herself as read out the questions out loud. Obviously you can't do that in paper, but isolated, she wants to do that. And she emailed Top Hat and to CDECB, and they said no, you couldn't mumble out loud. Then you must be saying the questions to someone who's recording them or something like that. So I know it's hard, but try to just be in an empty room. Try to keep your eye on the computer. If they see supposedly there's some sort of algorithm that tracks your eyes, and if your eyes move off the screen too much, a proctor will flag you and see what you're doing or something like that. So yeah, just try looking at the screen, look at different parts of the screen if needed be. And definitely have yourself in an empty room. Don't talk to anyone and stuff like that.
So we cannot put a wall clock too. We cannot look at a wall clock then for that timing. Only
Correct. Yes, there is a clock in Top Hat.
It's just the remaining. It's when you're used to your wall clock. Oh, it's 10:30. Because it's a minute per question. So you're thinking, I'm just saying that your eye should be fixed on that to make sure, because I called them and I didn't ask that question.
Mm-hmm. Yeah, so there is a clock. Figure out how to do it in Top Hat and then just follow that. But no, don't stare at something outside of the screen, or else they'll flag you and the proctor will come on. And that's the last thing you need during a test, to have some proctor ask you what you're doing.
Yeah, okay, maybe I'll just remove the clock then.
Okay. Let's see here. You can skip. Yes, during the honeymoon period, you could use a bit of a different dose. Thank you. Thank you. Yes, that's how I understand it, like a bell curve. That is funny, Kristen. Yes, thank you, Kristen. Yeah, it'll be very similar. My tests are harder. People find that my tests are harder than the actual exam. I did it that way on purpose so that you're a little bit extra prepared. So yeah.
But AirPods is fine, right? It says there, I read the instructions, AirPods as like noise cancellation. I have the 2022 handbook. It says AirPods, not headphone. So that's why I have my AirPods.
Okay, then that should be okay. That seems awfully suspicious though, because like, not that you would, but you could just have someone recording the guidelines on your AirPods and put on loop. So I'm not part of the CDECB. I'm not responsible for their
I
rules.
asked them that because some people are doing mowing, something like that. What if it happened, right? I'm not just in case. So that's why I asked them, can I use AirPods as long as you put it in a noise?
Sorry, you're cutting out a little bit, Giselle. Okay. Vanessa, you have your hand up?
Yeah, thanks. I was wondering, because it came up a few times during the exam on the effects of cannabis.
Mm-hmm.
I didn't see anything on cannabis in the guidelines. I can understand that it can, increase your hunger and it'll probably decrease your satiety, but now I can't remember, but there was something about having an effect with regards to one of the metabolic processes. Do you know where we can get a bit of information on cannabis? Or I don't know if I skipped something.
There is in my pathophysiology lectures, I mentioned it a little bit. I think there's a couple sentences on it. And in the essentials, there's like a paragraph on it. Yeah, essentially, I think all you have to remember is that cannabis generally worsens glycemic control. You're hungrier, you crave carbs, you're less satiety, so you eat more generally.
Okay. And I had one last question, because there's been a few questions that I ask, which studies have shown macrovascular, an improvement in macrovascular outcome, myocardial infarctions, for example. And I understand that all the studies didn't really show that right away, but when they did the cohorts, 10 years later on,
the legacy effect,
that's when they saw it. But so we still say that those studies at that time did not show those effects, but we saw them later on.
The initial results did not show any benefit to cardiovascular. Yeah. I'm just going to try to get through the messages. I see I have 65 new messages. So I'm just going to try to get through the messages before answering any more questions.
I was just going to add, for the cannabis in the essentials, the binder, there is something there.
Thank you, France. Yes. Okay. Marza, wrong answer will affect the scores negatively. No, you just get 0 for it. And if it was a pilot question, then it doesn't score anything at all. ICR not as much focus on insulin. Yeah, Appendix 9 is all I would do. My cheat sheet I made for the ICR and ICF and all that stuff, I think that they're getting less and less for that on the exam. That cheat sheet is more for like real life practice. I was frustrated that no one had like a central definition of it, and I was wondering where it came from. So just use that. I think it's very useful for real life. So just memorize that for real life. What was the patient's name? Sarah Hudson. Okay, I don't know what that's talking about. would aerobic post-resistance help with hyperglycemia rather than hypo? So aerobic doesn't cause that same spike in sugars as high intensity exercise causes. So I don't think it would. Exercise is tricky because it can affect people up to like 12, 24 hours afterwards. What you're doing is you're slowly exhausting the glycogen in your body. And then when you're ingesting sugar, instead of it staying in your blood, the rest of your body's like, hey, no, you've exhausted all my glycogen. I want that first. And it grabs it out of the blood and turns it back into glycogen. So that's why people are sometimes at risk for lows after exercise. Okay, yeah, I've never actually seen this. Mike Riddell. Actually, yes, I think he's one of the other ones. Mike Riddell and that lady from U of A are like, I think Mike Riddell actually, if you look at the studies in the hypoglycemia chapter, it references some of the studies. So yeah, that would be great. I'm going to save that for later. Thanks, Kristen. What test should be done for what type? I'm not sure what you mean by that, like in terms of sugar or like retinopathy. Amrit, are you still online?
Hi, Asmund. Yeah, I was just asking for the type 1, if the child has to be diagnosed, then we should do fasting or random only? Or A1c, you said A1c is not, it can't be appropriate, right?
Well, yeah, the A1c is not appropriate because children tend to convert to type 1 much faster than adults. Yeah, whatever, like, I don't have any experience in pediatrics, so whatever it says in the pediatrics guide, the pediatric chapter is what you would go with.
Okay, thank you.
No problem. Option scan manually. Yes, I know top hat isn't perfect. Your face cam with glasses. Okay, so that's good advice, Kristen. Thank you. You might have to take your glasses off for the face scan. Yeah, I have like super thick glasses, and so maybe it distorts my face or something. Okay, pics, scan, yep. Just want to confirm that on a sick day to not stop. Yeah, so for sick day management, you don't stop their, you definitely don't stop their basal insulin, but if they're not eating, if they're usually take 45 grams of carbs with lunch, but they're not eating any 45 grams of carbs, and you wouldn't do the bolus. But what you would encourage them to do is try to get 45 grams of carbs from Jello or juice or something like that, and then give them the usual 45-gram bolus. But you don't bolus if they're not eating. Like you can do it to correct, but you don't bolus for a 45-gram carb meal that you're not having. What's the policy on pets on Top Hat? That's a good question. I don't know if they'll accuse you of cheating through answers for your cat. I would assume not, but I don't know. Okay. Oh, depends on who's proctoring your glasses. Yeah. I believe you can sign in Top Hat a little bit earlier to try all that stuff before the exam starts. Can you close your eyes when you think of questions? I would assume so. Like they expect you to be human for these things. Oh, that's annoying. Header. I believe someone said you can do iPods, but you can't use headphones. Hopefully they don't think you're cheating if you close your eyes. cheat in eyeballs. That is funny. Yes, as Kristen mentioned, you don't hold sick day. Perfect. That's exactly what I said. Great. Yes, you have to tell them if you're going to the washroom. I believe you call a proctor, and then
there's a sign. You flash the sign. Basically, there's something said washroom, and then you can go. I think that's basically what it. I don't think you have to call somebody. No.
Okay, perfect. Okay. That's a good question. I didn't have to go, so I didn't run into it. Yeah, I don't know why AirPod would be okay, but not headphones. Yep, there's like a paragraph or two in the Cannabis in the essentials. Wow, I still have 69 messages. You are allowed a calculator on Top Hat. I believe that they changed that. In real life, with the paper, you're not allowed a calculator. Okay, so no. So GLP-1s, only Trulicity has been shown to us, which is dulaglutide, has been shown to have primary prevention. That's so. I guess they're a little bit here. Let me go to that. Not all the GLP-1s. Some of the GLP-1s don't even have secondary prevention, stuff like exenatide and stuff like that. So you have to look at each one specifically. So let me just take a look here. Yeah, so if they have various risks, then dulaglutide has the most evidence for primary prevention. The rest of them, like stuff like liraglutide and stuff like that, definitely have benefit for secondary prevention. Where is it? Where's that paragraph? Where's that diagram? Sorry. Right here, yeah. So risk factors. So yes, it's here for risk factors, but I would take a look at which ones have. I wouldn't generalize as saying that all GLP-1s are for secondary prevention and all SGLT2s are for secondary. Actually, even for Zika, most of its studies were done on primary, so you can't even say that. What I would go with is, see, even here, CV safety, but no proven cardiovascular. Let me just zoom in one sec. Let me try to zoom in here. Where's my zoom in button? Okay, there. Okay, so even here it says exenatide, no proven cardiorenal benefit. So these are the ones that I'd go with if you was asking for secondary benefit. Yeah. Yes, Alyssa, there is a digital top cut calculator. Says the exam starts between 8 and 9 a.m. your time. I believe it just started. I just logged in and I got in. I didn't have any issues, so I can't speak to that. Okay, yeah, that sounds reasonable. My cheat sheets, yes, thank you for that. Would it be that specific? I don't think it will be, but in real life, it's good to know anyway. So remember, secondary is for people who have had a heart attack or a stroke, and then primary is for people who haven't. Yes, it's challenging, but you would have to memorize it for the exam and in real life. Yes, oral semaglutide has not shown benefit. Oh, perfect. That's all the questions. Okay. Anyone have any other kind of last minute questions or concerns?
I just had a quick one. So in the guidelines for SAD-MANS, it says just sulfonylureas, but then in the quick reference guide from 2018, it says it adds the repaglinide, right? It just says sulfonylurea and other secretagogues.
Yeah, so that's so vague. Like, so on exam form, someone pointed that out as well, and I decided to remove repaglinide. The reason for that is repaglinide is actually not cleared very much through the kidneys. It's mostly cleared out for the liver, and when you're dehydrated, it's your renal function that suffers. So I know that's kind of a gray area. On the exam, if it were me, I would choose the repaglinide to continue that within.
So just go with the sulfonylureas.
Yeah, that's what I would go with for the exam. In real life, I'd probably be more on the cautious side and stop the repaglinide as well. But I know it's kind of that part is kind of unclear. Okay. Can you remember Orr's question, motivational interview? I don't remember that. But repaglinide is recommended as the answer in requests related to facts and can be taken or not taken with meals. Yeah, so if you're a sad man's and you're not eating, then you would skip it anyway. I just had a patient today, 50-year-olds, no statin on file and no ACE and RB. Do we add a statin anyway? Okay, let's take a look at that. So the best, Fatty, the best thing to look for that, actually Diabetes Canada, the website has a good tool for that. You can find it right here.
The healthcare provider. It's actually good. Yeah, the interactive one.
Yeah. Am I not seeing it? This one, right? No. Here we go, interactive. Yeah. So you can just go through this one. So let's see here. 52-year-old, does he have, Fatty, does he have clinical? Okay. Oh, there's more conversation.
I believe you go to the prescription one, and then it will tell you a question and the age and what medication to add.
Yeah, so you can do it this way too. So let's just answer Fatty's question. So 52, but they don't have no, but they're over 40, so they would be on a statin. Yeah. Yeah, even though their LDL is on target, a statin would further decrease their cardiovascular risk. Yeah, just like Alyssa mentioned. It was meant to be substituting for an older intermediate insulin in the question. Okay, could you email me that, Kristen? I have like 600 questions, so I can't remember that particular one at the moment. Or, oh yeah, you should probably, didn't I have a thing on that on my website? That would be useful to know for, yeah, just affirming them, rolling with resistance. That would be useful to know for the exam, that acronym. Yes, technically, even though the LD is 1.5, they would still be put on it. As per the guidelines, they might argue with you. So in real life, it's actually kind of hard to get people onto statins because they read on the internet that it's like the devil or something like that. So technically for the exam and the guidelines you would, but in real life, you might have a difficult time trying to actually get them onto it. Where's my chapter on that? Yeah, so learning about motivational interviewing, you can Google that ORS and it'll have more information on that. But I believe I have some stuff on like rolling with resistance and stuff like that. Yeah, it's kind of like this stuff, motivation and interviewing. Just try to know that for the exam. Okay, yes, that's right, it's correct. Okay, so there's about 3 minutes left. Anyone else have any last minute questions?
Hi there, sorry, this is Alyssa, hello.
Oh, hi, Alyssa.
Hi there, I just had a quick question about like screening for nephropathy.
Mm-hmm.
So my understanding is that if one of them are abnormal, then like you would have to retest it within 3 months, like EGFR retest in 3 months, and then ACR test it 2 times again in the next 3 months to confirm CKD, correct?
Yes, let me just double check.
Yeah, and then I just saw like on the flow chart that it says like if the ACR is over 20, even just like once, then that means it's CKD is diagnosed for sure already, or do you no longer need to do a confirmatory test if it's the ACR is over 20?
That's a good question. For the exam, it looks like you don't. It looks like you just skip.
Okay, I just wanted to clarify. So if it's like microalbuminuria over 2, then you would need to confirm, but if it's over 20, then it's like, okay. And then EGFR is like, say 80, then it's like, okay, well, that's CKD for sure, right?
Yes, I believe so. Can I make that larger? Okay, let me try to make that larger. One sec. Okay, there we go. Yeah, like so the problem with ACR is that it's quite variable. It depends on the day and depends on it has a lot of factors. That's why you have to retest it 3 times. But I guess if it's 20, then then you can be sure that it probably is CKD.
Okay, perfect. Thank you so much.
Yeah. Okay, wonderful. Well, I wish you guys the best of luck on the exam. Remember, here, I'm just gonna go back to the tips. Remember to, whoopsies. I don't know if you can see, but I've got all these windows in my way. There we go. So yeah, this will be updated on the webpage. Try to remain calm. Try to go for your first answer. Try not to waste too much time on a question. It might be a pilot question. Try not to overanalyze the question too. At the end of the day, the exam people are people like me who, you know, like in pharmacy, if you were making like 200 grams of diclofenac gel and you made 199 or 201, I'm not going to, you know, remake it to make it exactly 200. So if for a question, the answer is right 99% of the time, then pick it. They're not going to, there's no question that's going to be 100% right. And the worst is when, this is where people who change their answers kind of hiccups for themselves. They'll see an answer, they see it's 99% true, but then they'll concentrate on the 1% and try to focus on another answer. You know, the people are doing their best trying to make, they're humans too, they're trying to make answers that are hopefully around 99% correct. So just go with that one and go with your gut reaction. Yeah, perfect. Okay, yes, thank you. Yes, thank you to everyone as well. I've also taken some time off in the next couple of days, so I'll be pretty active on the forum. If you do have some questions, put it there. Like, I won't be there all the time, but I will try to answer your questions as soon as possible. Yeah, thank you, everyone. Thank you, everyone. You have, you know, keep calm on the exam. Best of luck on the exam. And yeah, thank you for attending this presentation. Okay, so let's end this.